Good evening, ladies and gentlemen. It's a great pleasure to be talking in this conference. I'm grateful to the organizing committee, especially Dr. Sohail, for inviting me to speak about a very important subject in terms of stroke rehabilitation. So first of all, let me say I have no declaration of financial interest to declare for this presentation. This is a brief overview of my presentation, and I will be devoting most of my time concentrating on the management of post-stroke spasticity. So let's start with stroke. We all know that stroke is the leading cause of death in the world and a major reason for adult disability. And one of the factors that sometimes can have a bad prognostic effect on the outcome of stroke during the rehabilitation process is the spasticity that some of these patients would develop. And therefore, it is important to talk about post-stroke spasticity in the context of stroke rehabilitation. We know 30% of stroke patients die within the first year after stroke. And we also know that due to the excellent acute management of stroke these days, the mortality rate has decreased in the Western world in the recent years. But absolute annual incidence and disease burden is increasing because of the increasing age of the population. From the rehab side, we know that over half of the stroke patients require therapy input during the first year to improve the functional ability and to reduce impairment and disability. So what is post-stroke spasticity? So Lance, many years ago, put together a definition of spasticity. And according to Lance, velocity-dependent intrinsic resistance to passive movement of limb in people with upper motor neuron syndrome was considered as spasticity. Over the years, we have found out that it is not only a motor disorder, but has a big sensory component to it. And therefore, recently, the European interest group has redefined spasticity, and now we can define spasticity as a motor and sensory disorder characterized by increase in tonic stretch reflexes with exaggerated tendon jerks resulting from hyperexcitability of the stretch reflex. Now, how common is this disorder in the context of stroke? We know from different epidemiological studies that spasticity occurs in almost 25% of patients and can happen very soon after stroke. We also know that the overall prevalence increases to 38% of patients surviving the first stroke, and the incidence of spasticity in stroke patient increases if the patient has recurrent stroke. We also know that almost 15% of the patients suffer from severe or disabling spasticity. So spasticity is quite a significant impairment after a stroke in quite a significant number of patients, as shown by these figures. A very quick word about pathophysiology, and we know that the mechanisms underlying normal muscle tone are quite complex. And we have also found that spasticity has neural component and non-neural component. And it is very important that we tackle both these components when we are managing spasticity. After stroke, we know there is loss of supraspinal control over the local spinal mechanisms. And this loss of inhibition in the stretch reflex in the spinal cord then manifests itself in increased spasticity. And on the other hand, we also know the muscles become weak after the stroke, and because of weakness and disuse immobilization, there is muscle fiber atrophy and deposition of excessive connective tissue in the muscles. And this combined together increases stiffness of the connective tissue, which then increase the spindle efferent responses. And this triggers a vicious cycle. So it's a combination of neural and non-neural factors that contribute to spasticity. And we need to tackle both of these components, as we will see as we go along in the presentation. So what do we know about spasticity? We know that not all of the patients suffer from spasticity after stroke. But if you don't treat spasticity, then there can be a permanent loss of joint range within a very short period of time. So it is very important to assess the patients for development of spasticity. And our experience has shown that if you intervene early on, then you can manage spasticity and prevent all the complications associated with it. We also know that if untreated, the spasticity can peak around 1 to 3 months, and then if not treated, impairment continues over a prolonged period of time. The abnormal postural patterns, I'm not going to dwell on that. We all know the abnormal postural patterns that develop in the stroke patients, with flexor pattern in the upper limbs and the extensor pattern in the lower limbs. So what happens when the patient develops post-stroke spasticity? Not a lot of people realize that spasticity actually is quite painful at times. Because of the weakness which the patient is already experiencing after stroke, and if there is a combination of spasticity and pain, there is less movement, contracture of the muscles, and then that results in loss of function. And when there is loss of function, and that results in poor physical and emotional health of the patient. And you can see how everything is connected and how spasticity can affect the ultimate outcome after stroke. So if you want to see the sequelae of spasticity in WHO ICF framework, you can see that a patient develops impairment, muscle spasms, abnormal trunk and limb postures. Sometimes, we talk about the importance of pain, and this all results in difficulty with seating, posture. Patient experiences fatigue, contractures develop, limb deformities, development of pressure ulcers, and other tissue viability problems. And all this combined together with pain that results in distress and low mood and poor sleep patterns. And then it reflects in the loss of active function and loss of passive function. And in the rehabilitation world, we have devoted a lot of time in improving active function, which is extremely important, but we sometimes tend to forget that the passive function is as important sometimes as the active function, because if you lose the passive function, then it becomes difficult to care for the patient. So there is more carer burden, difficulty in looking after the patients, difficulty in seating or bed positioning. And so we have to see how impairments are affecting both the active function and the passive function. And then all of that obviously, has to be seen in the context of the participation of the patients, and it results in poor self-esteem, self-image, reduced social interaction, great impact on family relationships, and ability to go back to work. So let's look at some general principles of spasticity management. And these general principles are applicable to most of the impairments, the neurological impairments in the context of wider rehabilitation. Obviously, if you're going to treat or manage or plan a rehabilitation program, that has got to be goal-oriented. And I have seen many times the people treating spasticity for the sake of it, rather than seeing how this treatment is going to help the patients. The patients and carers should be at the center of the rehabilitation process. And this has to be done in an IDT environment, which we're going to discuss later. The regular follow-up and monitoring of these patients is extremely important because obviously with spasticity management, we can't cure spasticity, we're going to manage it and manage it in a way that results in prevention of loss of active and passive function. Ultimately, any rehabilitation program, the goal is to make the patient as independent as possible. So the self-management programs, while we're doing the active management, are also very important so that patient can manage its condition. It's a long-term condition, stroke and associated spasticity, so that self-management programs enable the patient to manage their problems independently in the long run. We also need clear deferral pathways because we're going to talk about the IDT environment, but we also need to understand that we sometimes, when we are managing these patients, we need help of our colleagues in pain management, in neurology if the patient has recurrent strokes. Sometimes we need surgical intervention or problems of bladder sorting out. And sometimes we need help from the other neuropsychologist or psychiatry colleagues. And so we should develop, when we are developing a spasticity program, very clear pathways to specific teams so that we are referring these patients to professionals who understand the spasticity and the issue related to it. If you are developing a clinic, you may need to make sure that the patient has access, good access to the clinic, and you have all the facilities in the clinic with all the appropriate equipment and working aids. And you have multiple rooms available for the clinic because it takes time for the patients to get settled when they come to the clinic. And if you have multiple rooms available, that is quite helpful. Access to nearby gym is extremely important, especially if you are looking at the gait of the patient in the context of spasticity management. So let's deal with the management program. Some important facts to look at. We all realize that not all spasticity is bad. So you don't need to treat spasticity because some patients are using the spasticity with their mobility, with their transfer, that stiffness is important. And so you need to understand that you have to assess the patient, look at the goals, what we're trying to achieve, and how the patient is using that spasticity in terms of functional abilities before deciding to treat it. We also need to understand that this spasticity is not constant. And the intensity and severity of the spasticity changes from day to day, and sometimes also during a single day. So you might find that the patient comes into the clinic and has very little spasticity, but complains bitterly about spasticity and the problems associated with it. So we need to understand that sometimes you need to see a patient a few times to really get a grips with the assessment. You also need to understand every patient is different and they respond differently to the pain or the stiffness associated with spasticity. So you have to treat the patient and not the spasticity as such. We also know that spasticity changes as the disease progresses. So this is very true of patients with multiple sclerosis, but also with stroke, because if a patient has recurrent stroke, then there is high chance that they have increased problems with spasticity. The management trigger factors is important, and we're going to talk about that later. So the management of spasticity is quite complex, has got to be done in IDT environment. We talked about that, and we have a lot of guidelines and algorithms now available which are based on good evidence. So it is good to have access to the guideline algorithms, but at the same time, we need to understand that these guidelines or algorithms are intended to augment rather than substitute for good clinical decision making. And also, we need to understand that linear approach or sequential approach may not apply to every individual, and we have to see what is most appropriate intervention for a patient at that point in their disease process. And then not to forget this, guidelines for adult stroke rehabilitation and recovery, endorsed by the American Academy of Physical Medicine and Rehabilitation, and produced by the American Heart Association. And it also gives a very nice recommendations with good evidence base. They touch on the use of botulinum toxin, anti-spasticity agents, physical modalities, intrathecal baclofen, and postural training, and even use of splint therapy. So well worth having a look at all those. So before you manage any spasticity, you have to look at what the distribution of spasticity. So you can classify spasticity according to distribution into focal, that means involving one limb, multifocal, segmental, one, both of more than one limb is involved, and then global or generalized, where the patient might be experiencing generalized spasticity. We also need to understand that spasticity sometimes is more pronounced when the patient is static, and in some patients it manifests more when the patient is mobile. So you need to assess spasticity, in both at rest and while the patient is mobile. And then we talked about different patterns, and sometimes you experience or you see the mixed pattern in a patient. So this is the overview of the management strategy for spasticity. This is applicable to spasticity developed after any neurological upper motor neuron condition. So you can see that the first step is prevention of physical provocation factors, trigger factors, and which is applicable to all the patients. And then again, they have emphasized the IDT environment and team decision making along with the patient, establishing the goals. And the first step, whether it is a focal spasticity, global spasticity, or segmental spasticity, is the deployment of the physical treatment. So that is the background in which the patient should be treated before you start thinking about using any pharmacological agents. And then if you have generalized spasticity, then you can better to use oral medication. If you have segmental spasticity, then intrathecal baclofen therapy should be considered. And if you have focal spasticity, then botulinum toxin therapy is very effective. And most of the patients you have to combine these together as we go along. See that. So let's just look at the first steps. Obviously, when you see a patient, you have to identify new onset or change in spasticity. You have to take a detailed history. You have to document all the symptoms, and then you do a detailed examination, and then the documentation of the severity of spasticity according to the scales that we'll talk about. In terms of symptoms, we already talked about that. You can have spasms manifesting clonus, stiffness, pain, heaviness, disturbed sleep, Patient obviously has weakness in the limb because of the stroke. There's reduced dexterity because of the weakness, and also because of sometimes with the spasticity. And the patient obviously feels fatigue and tiredness. And when you are doing a detailed neurological examination in terms of, in the context of spasticity, it is good to document the range of motion at different joints, especially in the limbs in which the patient has spasticity issues. You document the severity of the spasticity, either using the modified Ashford scale or Tardy scale. Both are not perfect, but you have to use what is available. Modified Ashford scale is easier to use, has issues with validity and reliability. On the other hand, a Tardy scale is it takes more time to do in the busy clinical setting. Obviously, then you if in the context of goal setting, goal attainment scale becomes quite important. And then you have other impairment disability instruments that you're going to use as you would use in any neurological disability patients. For example, if you're looking at balance, the balance scale, mobility, walking tests, etc. And so these are the trigger factors we talked about, and this is very important whenever the patient comes to you, initial consultation, or when the patient comes after change in this spasticity, that you look at very closely. What is there any new underlying trigger factor which is contributing to increase in spasticity? And that might include pain. And this is a difficult thing because spasticity results in pain, but pain anywhere again triggers spasticity. So it is like a vicious cycle. And whether it is pain because of spasticity or because of any secondary condition, we have to treat pain as best as we can. Again, any underlying new infection can aggravate spasticity. Bowel and bladder issues have a big role to play. If the patient develops any pressure sore, then that also aggravates the spasticity. And this is a big list. And when we are looking at the patient and assessing the patient, we have to be careful about all these things. And also to keep in mind that if spasticity changes in any patient suddenly, then you have to think about disease progression. Is there a new small stroke that has happened? Or MS has relapsed. We talked about the importance of classification of spasticity, because on the basis of that, you are going to devise your pharmacological treatment plan in the background of the physical modalities that you will employ in IDT environment for these patients. So most important thing, I think, as a rehab physician, I think, when you are developing any spasticity management program, is identifying goals with the carer and the patient. It's very important. We need to address what we're going to achieve. Is it because we want to improve passive function or active function? Are we concentrating? The goal is to decrease the pain which is associated, or the development of the complications that are associated with spasticity management. So identification and agreement of the goals, and these can be primary goals and some can be secondary goals, but at least we all know as a team, and I'm talking about patient care and the family as well, that everybody should know what is the goal of the treatment. And we already talked about the background rehabilitation, physical rehabilitation strategies under the umbrella of which we are going to put together a pharmacological treatment plan. This should include, and these are applicable for all the patients. So there should be a stretching program trying to increase the range of motion. strengthening of muscles, weight bearing is extremely important at it. Stretches the muscle in itself. Some patients might need serial casting and splinting, and the positioning of the patients is so important. And here is where the role of the specialist nurses and occupational therapists come into play. And one of the things I think sometimes we forget is educating the patient, family, and the carers about, and so that about spasticity. And they should also be part of the team, and the education and the information is vital. We have seen over the period of time that the modalities as an adjunct to the pharmacological or physical rehabilitation program sometimes are very are effective as well. We have seen a few papers about use of functional electrical stimulation after botulinum toxin therapy, while the other do not have that kind of evidence base. For example, hydrotherapy, transcranial magnetic stimulation. But that does not mean that we should not use it in the patients, because, as I said, every patient is different, they respond differently to different modalities. But we just need to keep in mind that is an adjunct to the treatment plan. Very quickly about the oral medication, we always should start with a single agent, depending upon the side effect profile, looking at the patient, looking at the cost. We should increase the dose of these spasticity medication gradually, because these patients with neurological impairments, the chances of having the side effects are more, especially if the patient has cognitive impairment as well. And sometimes then you combine the oral medication with other treatment modalities. So the primary medication, the first-line medication, we tend to use obviously our baclofen, tizanidine, and dantrolene, with baclofen, tizanidine acting at the central nervous system level, while dantrolene effects is more at the level of the muscles. Gabapentin, benzodiazepine, again, are beneficial, but not first-line treatment drugs for spasticity. The issues with all these medications is the side effects. And as I said, these patients of neurological impairment are much more sensitive to the side effects, and all these medications have side effects related to sedation, hypertension, and if the patient has cognitive impairment, then it can worsen that situation. And sometimes if you apply bigger doses, then it can induce weakness in the muscles, which are already weak. And again, to emphasize that it is more suitable for patients with generalized rather than focal spasticity. Now, botulinum toxin therapy has been extremely beneficial for the patients, especially who have focal spasticity. And there are many advantages. One is that it is quite effective, and that has been produced by the research literature that we have seen in the last many years. We have also seen that botulinum toxin therapy is very safe with excellent side effect profile. The disadvantages obviously are that it is expensive and requires expert IDT environment. So there's a lot of evidence base available. This is produced by the American Academy of Neurology, and you can see that most of the formulations of botulinum toxin A are effective for upper extremity spasticity, more for the passive function rather than the active function. Similarly, for the lower limbs, initial evidence was more for upper limbs, but lately lower extremity spasticity has been treated quite effectively with botulinum toxin injection therapies, and the data is coming that these are safe and do reduce lower limb spasticity. So the evidence is still not there for significant improvement in active function, but we all know that these are very effective for improvement of passive function. Now, most of the patients with spasticity require combination treatment. So you start with, for example, in a patient with oral medication, and then you realize that although there is generalized spasticity, but one of the muscle group areas is more stiff and causing more management or care issues. And in that situation, rather than increasing the dose of oral medication, which then increases the side effect, you can employ botulinum toxin therapy targeting that specific group of muscle. And also sometimes because the different oral medication work in different, the mechanism of action is different. Some are affecting it, as I said, on the sun, in the brain and the spinal cord, and some at the level of the muscle side. Sometimes combination of oral medication is quite effective rather than increasing the dose of one particular drug. So, it is a combination of different treatments which, sometimes beneficial, and so it is very important that the team treating the patient is well experienced in the management of spasticity and has a good feel of use of different treatment modalities for spasticity. And just to emphasize again that when you're using medication, it is always important that the patient has intensive physiotherapy input, because if you are not employing the therapy part, then sometimes it becomes useless to use the pharmacological treatment for these patients. Again, the intrathecal baclofen therapy has been proved to be quite effective, especially in patients who have segmental spasticity, and a lot of evidence is coming out, especially in the recent years, that it is quite effective and safe as well. Obviously, it is an invasive therapy. You're delivering the baclofen through a pump delivered to the spinal cord, and therefore it is not for every patient. And so the patient selection is very important, and that is why I strongly believe that the decision for the pharmacological treatments should be done in a center where they have active spasticity management program with a specialized team who have experience in using all the treatment modalities, and then the patient should be assessed by the IDT before a decision is made about trying intrathecal baclofen or botulinum toxin therapy or other procedures. Then in the past, we have used nerve blocks with phenol, use intrathecal phenol as well. Obviously, these are quite destructive processes. So since the use of the botulinum toxin therapy, people are using it less as compared in the past, but they have a role to play as well in expert hands. Again, surgery is important, especially where the patient has developed contractures or shortening of tendons. But my belief is that as a physician, we should not allow the patient to reach that stage. But again, if that is required, then again, it has to be assessed by the IDT team, and a team decision should be made to refer any patient for surgical intervention. In my experience, I have seen patients who have been surgically treated without the management of background spasticity, and that then doesn't produce good results. So whatever treatment plan you put together, it has got to be reviewed with outcome measures, the feedback from the patient and the family. The patient should be seen regularly in the clinic, and the patient should have modification of treatment whenever is required. So regular follow-up is extremely important. And sometimes you don't need that follow-up in the specialized clinic, of course, but the therapy team or the family should be taught how to monitor the patient and come back to the treatment team if anything changes. So in the end, I think the lesson is it is extremely important to manage these patients in the IDT environment. The physical modalities should always be used first, along with management of the trigger factors before pharmacological treatment is decided on. And the important thing is that these patients need monitoring, and monitoring just to make sure that things don't deteriorate when the spasticity changes or fluctuates. So with this, I finish my presentation, and thank you very much for your time.